Venkatesh. Venkatesh, good morning.
Good morning, sir.
Good morning. Can you open the, unmute, start my video?
Yes, sir. You can start your video, sir.
Okay. You can open the forum for others also.
Okay, sir.
You are not allow me to open my video. Venkatesh, I couldn't open now.
Sir, sorry, sir. I didn't get you.
And I cannot start my video now. May you allow me to start my video?
Yes, sir.
It is written you cannot start your video because the host has stopped it.
So now you can start your video, sir.
Yeah, correct. Thank you. Thank you. Now I can open.
Good morning, Madhu sir.
Good morning, sir. Good morning.
Madhu, how are you, sir?
I'm fine, Suresh.
Acha, so we had an internal discussion. I don't know whether they communicated with you, Sudhir and Roop and all, but everybody was overwhelmingly in favor of your keeping it indefinite program.
Okay, thank you.
I only said that Madhu asked that, look, I'm going on whether anybody has any objection. But to me, this is the best program, and we have to be thankful to Madhu that he is agreeing to do. And everybody supported overwhelmingly.
Yeah, thank you. I was hesitant because initially I was asked to do only for 1 year. So I don't know whether I overstepping.
Madhu, we have to be grateful to you. We have to be grateful to you.
No, it is my privilege, my honor and privilege to be with you.
We don't know. No, because Fine also has its agenda to do other programs. In future, they may come out with some other programs. At that time, we will discuss with you. But I think you should always be part of the Fine.
Okay, thank you.
Thank you, sir. Thank you.
Shall we wait for 2 more minutes?
Yeah, it's up to you. You're the boss.
Just if people are joining, just wait.
Good morning, sir.
Good morning. Good morning. We'll wait for 1 more minute and then go, okay?
Aberu Ganga.
Hello, Madhu sir.
Yeah, please join. Hello.
Sir, we had discussed one case previously where there was a patient who initially, from clinical history, we thought peripheral neuropathy. He had this sensory symptoms up to his mid thigh and in his hands. And the thing initially it was a neuropathy. Then he had brought the MRI, which showed a spinal epidural fistula.
Yeah,
And
yeah.
then that patient, could he have doubted that he had a spinal cord problem because his sensory symptoms were limited to the hands and the upper limbs, but the sensory symptoms had reached up to the mid thigh in the lower limbs. Had this been a peripheral neuropathy, by the time the symptoms had reached the mid thigh, it would have reached up to till the elbow in the upper limb. So from that, could we have?
Yeah, absolutely correct. Absolutely correct. But the problem is, examination we couldn't document. That is a little problem. Otherwise, history-wise, as you said, it's correct. We should have suspected. Exactly. Shall we start now?
Yes, Madhu. Yes, Madhu, we should.
Okay. So good morning, everyone. This is I think, a 44th session on the challenging case series. As usual, I will start with a small case first. My screen is visible now, no?
Yeah.
Okay, we'll start with just 1 minute. It's a story of a 10-year-old boy. He noticed squint for the last 6 months after a quarrel in the house. No diplopia or pain in the eye. No relevant history in the past. This is the patient. This is the squint you can observe. This is how parents noticed it. He did not have any complaint. Examination, pupils were normal. The eye movements. Observe, I will tell the diagnostic. Right. Okay, what is the diagnosis of this patient?
Convergent spasm.
Convergent spasm. Okay, any other possibility?
Convergent spasm, possibly functional.
Okay, anything else? Anyone else want to make a diagnosis? Any PGs? But convergent spasm, it should be bilateral. It's only right side is adducting, no? It's unlike a convergent spasm. Can't be lateral rectus weakness. So look at the patient. It's got a left eye is stable, right eye is adducted. If it is converging, left side should have been converging as well.
So the Mari it's happening on both the eyes, no? Intermittently?
Yeah, exactly. Like, you can take the video once again.
Not being seen, sir.
Video is not seen?
It's seen, sir. It's seen.
And Ruba, I'll play once again. It is seen. Ruba, you can when log in again, then you'll be able to see the video.
Okay, sir.
There is a catch in
movements.
the lateral rectus.
Pardon?
There is a catch in the lateral rectus movement. It is restricted to a point and then it catches up. So there is some mechanical restriction
Congenital. This
Yeah.
is there, sir. So he's able to look into the right side, but not maintaining that particular direction because of there's a pull or something. Some catch is there to bring back or something like that.
Okay. Let us see. I'll show you once
It's
again.
not an acquired weakness.
Okay, right. It's not bilateral actors unlikely, but we can't rule it out the possibility. Now let us see. This is a squint. Basically, this is, in fact, I tell you, this is the commonest problem which comes up with the OPD. Unfortunately, many of them go to the ophthalmologist and they send off without making a diagnosis. Very, very commonest problem. See, this is a squint. It can be, is it right lateral rectus weakness or left lateral rectus weakness? Both are possible. Suppose this person, suppose he is viewing you with the right eye, left lateral rectus is weakness. Suppose he is viewing you with his left eye, then right lateral rectus is weak, correct? We don't know because there is an adduction of the right eye or a left eye. So the first step is to find out whether it is, which eye is deviating, which is a squinting eye. So the simple test you do is the cover uncover test. So he has got an exotropia, that is a manifest squint, which is an esotropia on the right side. So it can be a weakness of one of the adductors. Let us see what is looking now. Now let us see what we do. A cover uncover test. I covering it. Left eye is right eye deep, comes back again. That means that is deviate. Now putting the cover on the right eye, nothing happens.
Okay, very good.
That means what? Putting a cover on the right eye, nothing happens to the left eye. Putting cover on the left eye, right eye goes outward. That means he has got the deviating eye or the bad eye or the lazy eye is the right eye. Left eye is the normal eye. So the right eye is abnormal. That's the first conclusion. So this can be either due to a lateral rectus weakness or could be due to a concomitant squint. Okay. Then the question is concomitant squint. What will you do to differentiate whether it's a concomitant squint or paralytic squint? Do the duction test. Duction movement. See, in fact, in the first video itself, we can see his movement, lateral movement is full. The catch observed was actually not the catch itself because he is viewing with the left eye. When he is viewing with the left eye, the right eye becomes lazy. He does not move. But is forced to move, he can move. That is a classical of concomitant squint. Let us see the adduction movement here. By closing each eye, the ocular movements are all normal, no restriction. Goes out, maximum. Then come to the left eye, it's also full movement. Okay, that means it is not a paralytic strabismus. No, sometimes subtle paralytic strabismus you may miss sometimes. So what we can do is that the other test is what to do. What do you do for primary and secondary deviation? Okay, let us see this video now. Cover, see the deviation of the right eye, the deviate. Left eye is deviating less. Right eye is deviating more. Deviating is almost equal to that of the right eye. Now, what does it mean that the secondary deviation is equal to that of the primary deviation, less than the primary deviation? That means, what do you say like that is on removing the cover from the left, that the normal eye, the movement of interest, that the movement which brings back to the primary position should have been more if the right eye was having paralytic strabismus. I think I'll make it more simplified by the next 2-3 slides, which I have shown earlier. Now, what is primary and secondary deviation? Primary deviation is the deviation of the lazy or paralytic eye when the good eye or the non-paralytic eye is fixating the object. For example, in our patient here, this is the good eye, right eye is deviating. This is the primary deviation, the deviation which is observed. Let us come back now. Secondary deviation is the deviation of the good eye or the non-paretic eye when the lazy eye or paretic eye is supposed to fixate on the object. That is when you cover the normal eye. Secondary deviation is always greater than the primary deviation in concomitant strabismus or the paralytic strabismus because of the Hering's law of equal innervation. Let us say this patient has got, this is the primary deviation. This is, here the left eye is the good eye. He is fixing the object. There is inward deviation of the right paretic eye. That is the primary deviation. This angle is a primary deviation of the primary. Now, if you put a cover on the left eye, the right eye or the bad eye is forced to fixate on the object. Okay, so it goes like that. So the paretic, the bad eye or the weak eye is made to force look at the object. That means extra innervation has to go to the right lateral rectus for the right eye because it is paretic. Let's say extra innervation is now going to the contralateral eye, that is the left eye. The contralateral eye, the agonist is the medial rectus. So it goes excessively. So the good eye deviates excessively when that eye is covered and the paretic is allowed to fixate. Now this is the secondary deviation. So right eye is supposed to fixate, there is inward deviation, this can deviate. This is, you get the difference between the two. This is always greater. So in our patient, what happened was that when we are not seeing the movement under cover here, but when you remove the cover, you see the eye goes back. So that degree of movement you can see is more. So in the video which I showed before, now cover the left eye, the deviation should have been much more. When fixing with the right eye, paretic eye, left eye should have gone much more inward. But I think it's much more. That's not a paralytic strabismus. So what he was having only a concomitant squint, nothing else. So what will you do for this patient? There are two things which we can do. You can give a prism glass as opposed to the ordinary glass. The prism means that it can be base out prism or base in prism. That means the one which is the point is towards medial side or pointed towards lateral side, depending upon the isotropy and exotropy. If you put the prism glass, the right eye, the paretic, the so-called deviating eye can be made in alignment with the other eye. Because the patient has to look through the prism, so the eye deviates because you have to focus on the object. So that's a way, that's a treatment. Or you can do surgery to correct the squint. That's a treatment. So any questions in that? I think everyone understood what is cover uncover test and cross cover test. Am I audible to you?
Yes, sir.
Yes, yes, it is clear.
That's
Go ahead.
from that side. I was wondering whether I am audible or not. Any questions? Okay, then I will go to the next case. This is called a manifest latent squint. This patient has been having a latent squint previously. With stress and strain, this became manifest on a later date. Or it might have been there to a mild degree. The parents might have noticed it. One day when there's something happened, looked at the patient or some pain in the eye or something, then they detect that squint. That's the usual story. Now, this is another interesting case, 2-3 interesting cases. History of this 40-year-old man, history of progressive weakness of the left foot in the form of episodic invasion of the foot while walking, as well as loosening of chapels from the left foot for the last 2 years. There's no sensory complaint, no root pain. This is the video of the patient. His inflection was normal. Actually, the video was taken by the bystander. It's a not good video because he did not focus on what he wanted to focus. The extension was normal. See that one? The dorsal on right side is left side is. DHL is also weak on the left side. Plantar flexion was normal. DHL is weak on the left side. But support is long as it's not. But the reflexes, ejects were almost absent. Just reciprocal absent. We couldn't get even at 3%. Right angle was also absent, but just left angle was just this. And you can see that. He's the
അവിടെ ഒരു മരപ്പ്
he's
വരുന്നു
the
കാലിന് വെച്ചിട്ട്
focus
മരപ്പ്
of the deaf person.
ഈ കുത്തുന്നതും ഇതും വ്യത്യാസമുണ്ട്.
ഉണ്ട്
ഉണ്ട്. ഉണ്ടെങ്കിൽ മാത്രമേ പറയാം.
സാർ ഒന്നുകൂടെ കുത്തി ഉണ്ട്
ഉണ്ടോ?
ചെറിയൊരു മാറ്റമുണ്ട്
Yes, sir.
ഇതും ഇതും തമ്മിലോ
വ്യത്യാസമുണ്ട് ഇതിനെ അറിയാം
ഇതോ
Not feeling over the and selling yes.
ഈ പേരെങ്ങനെ
താഴോട്ടാകും ചാരി താഴോട്ടാകും മേലോട്ടാകും ഇച്ചിരി മേലോട്ടാകും
അതിനെ എനിക്ക് ഇഷ്ടപ്പെടുത്തോട്ടാ ലൂസാക്കിയേ. ഇപ്പൊ എങ്ങനെയാ?
താഴോട്ട് 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 മേലോട്ട് ഇച്ചിരി മേലോട്ട് അടുത്ത കാലിനുണ്ട്
ഇപ്പോഴോ?
ഇല്ല വെച്ചായിട്ട് അറിയാം
വെച്ചത് വരാം. ഈ പ്രശ്നമില്ല. ശരി, ഞാൻ ഈ വിരലിൽ പതുക്കെ തൊടും. തൊട്ട് അറിയാമെങ്കിൽ ഒന്നേ എണ്ണിക്കോളാം. അപ്പോൾ ഒന്നും തന്നെയാണ് കണ്ടടച്ചോ.
ഒന്നാ
The sensation is being normally
ഒന്നാ ഒന്നാ ഒന്നാ
ഈ കാര്യം നേരെ
So examination, weakness of left dorsiflexion inversion, detail the lower limb, both knee checks absent, angle left plus right absent, 1 plus left absent, right absent, sensation decreased pain over the left foot and absent vibration in the left big toe. However, patient could appreciate touch normally as well as JP sensation. So what do you think is the site of lesion in this patient? Likely diagnosis.
Right parietal.
Parietal lesion, why? If the
Because dorsiflexion.
inversion with the sensory loss, apparent sensory loss, not a typical sensory loss because he said touch is normal, JPs is normal. Vibration is decreased, pain is they are subjectively decreased.
Motor and sensory in the peroneals.
Yeah, may think of a condylar pulse, you know.
Yes, sir.
Yeah, that's likely diagnosis you have to think. Any other possibility?
L5 radiculopathy.
Yeah, the other possibility is L5 radiculopathy is another possibility you have to keep in mind. Okay.
The reflexes was maintained on the left angle, check, no?
Yeah, reflex is just elicitable. Yeah, all other reflexes were absent. Knee jacks were absent, right angle is absent, left is just elicitable. But L5 radiculopathy, angle jack will be normal. So this. So what do you want now? Nerve conduction. Normal CMAP, normal SNAP.
What was the plantar, sir? Plantar reflex?
Plantar was in flexor only. He walks with a foot drop. So the patient was examined again because there's a possibility of sensory conduction was normal. So we want to rule out a radiculopathy. So
അടുപ്പിക്കാൻ സമ്മതിക്കരുത്.
was very good. Very
ഇനി എൻ്റെ കയ്യിലോട്ട് കൊള്ളണം.
Was he diabetic?
It's not a diabetic. Hip extension.
പറ്റത്തില്ല ഇനി തള്ളു കീഴോട്ട്
Bilaterally.
തള്ളിക്കൊണ്ടിരിക്കും
ആ
Both sides hip
അടുപ്പിക്കാൻ സമ്മതിക്കുക അങ്ങനെ ഇരിക്കണം
Again, hip abduction.
അതേമാതിരി തളർന്നിരിക്കണം
അടുപ്പിക്കരുത്
അടുപ്പിക്കരുത്
ആ
Very good power. So what do you think now?
L5 radiculopathy is ruled out.
Okay, so what do you think? That's the thing. What is a likely possibility?
Sir, if there is nerve also, I have one doubt. How can I explain the bilateral knee-jerk absent?
That is difficult, no? Sometimes normally itself, some people have hardly elicit pull reflexes.
Okay, sir.
Symmetrically present, that you not give much importance unless he has got a weakness or something along with that.
Okay, sir.
So what do you think? Is grip extension bilaterally?
Sir, hip extensions are mainly L5S1 and abductors are mainly L4-5. So still it can go with the root.
No. I think both are L5S1 is dominating in even in hip abduction also. Not L5.
But the power is not so grossly weak. So I would still consider a radiculopathy or a cauda equina since it is on both sides.
Okay. But usually, okay, agreed with you, that possibility can be considered, agreed. But only on the right side, hip extension is weak.
Madhu, can it be some problem in the tendo achilles?
No, there's no problem there in that thing.
Sir, is it weakness of both extensors, no?
Both extensors. Not one extensor, both extensors.
So
Okay.
again, it can go with L5S1.
Yeah, but only thing is the right side. Phase one that the first muscle to be affected in EHL. L5 radiculopathy, the synchromon or the muscle segment pointing muscle is the extensor hallucis longus. So you can't have an L5 radiculopathy with the preserved EHL and weak hip extensor.
Could be L5S1 on the left side and S1 on the right side.
That's a possibility we can consider, but flexor pollicis long, flexor hallucis longus also is normal on the right side. Plantar flexor is not possibility. Let us see that possibility. So
Is the sensory, sensory is dependable, sir, or should we take away the sensor?
that's this up to you to decide, no?
Then we could think of any muscle issues which can cause proximal.
Right, that's the thing we have to accept. That this at this point of time, you would start thinking that you are not fitting with a nerve pattern or a radiculopathy because his right hip extensor also is weak, as Ruba correctly said. Then we have to may not. That's why sensory was on examination, but the true sensation which is abnormal was subjective. That is, subjectively he said when pain is less and vibration is less, but JPS is normal. And touch also is normal. So we cannot believe him totally. So, but you have to keep this. So I did a nerve conduct. Nerve conduct is normal. Sensory snap is normal. So that adds to the point that the sensory may not be genuine, especially with the finding of hip extension bilaterally. Now examine once again. Now look at here positive beavers.
തലയൊന്ന് പൊക്കാൻ ശ്രമിച്ച് പൊങ്ങട്ടെ
Now you can coming back. If you see the coming back, you can see it's got a positive view. Now, what do you think is likely to be having?
FSHD,
Facioscapulohumeral dystrophy.
FSHD type of muscular dystrophy.
Exactly. So, examine again here positive behaviors and what do you want to do? He was till that time examining him with the dresses on. Okay, we don't take come here at the lower limb, we don't ask him take out the shirt. So ask him to take out the shirt. This is what he saw. The classical appearance of the FSHD.
കൈ ഇങ്ങനെ പൊക്കാൻ നോക്കിയിട്ട് രണ്ട് കൈയും
Yes, but we can
ഈ കൈ താത്ത
the long forearm multi.
എന്നിട്ട് കൈ രണ്ടും പൊക്കി നേരത്തെ പൊക്കിയിട്ട്
His tongue goes backward.
കൊച്ചിൽ പൊക്കി നിൽക്കാൻ നോക്കി
I think it's observed it from the FSHD.
അത്രേ വരത്തുള്ളൂ കൊച്ചിൽ പൊക്കാൻ നോക്കിയിട്ട് മാക്സിമം അത്രേ ഉള്ളൂ
It tries more.
അത് ചെരിഞ്ഞ് അതിന് പൊക്കാൻ നോക്കിയിട്ട് മാക്സിമം ഇത്രേ ഉള്ളൂ
The left scapula going up, producing scapula.
എനിക്ക് ഇത് പൊക്കിക്കാൻ മുകളിലോട്ട്
Actually, fold, 2 extra folds here. One fold here, one fold here.
ഒരു മാറിയിട്ടേ
Okay, examine hypertrophy of the deltoid and forearm muscles, pupae appearance, scapula hump, and axillary fold. And the trunk goes back in extension or abduction to shoulders. Okay. This is a facial scapular humeral. See how it presented with full drop, no complaints in the upper lip. Now I'll go to
Sir,
another.
one doubt, sir. Sir, one doubt, sir. Sir, the way you were testing that flexion at the elbow, sir, can you show that again? Is it some, I mean,
In fact, I did not pay much attention to that. Once the diagnosis made, I was just going to that.
I was wondering if it was some special technique or something.
കൈ ഇങ്ങനെ
No,
പൊക്കാൻ
not like that.
രണ്ട് കൈ
So this is always aspect like that. Not the abnormalities.
What was the winging due to, sir? Which muscle?
I will tell that it, but here the winging was mainly for the trapezius.
എന്നിട്ട് കൈ രണ്ടും പൊക്കി നേരത്തെ പൊക്കിയതിട്ട് പൊക്കി
The shoulder is, the scapula is,
കൊച്ചിൽ പൊക്കി
the part of scapula is moving out, and the scapula is moved up.
അത്രേ വരത്തുള്ളൂ കൊച്ചിൽ പൊക്കാൻ നോക്കിയിട്ട്
See, depending upon which part of the trapeze is affected, the scapular deviation will vary. If the upper part of the trapeze is weak, there will be a drooping of the shoulder. The scapula will come down. The inferior part is affected, the scapula will go up, producing the scapular hump. The middle part is affected, and the inferior part, the scapula will move outward, and the upper angle will wing. So here, upper part is okay, the middle and lower part is affected. So that is the peculiarity of FSHD. It's not the pattern of typical whole, what do you call, whole trapeze is affected, part of the trapeze is affected. So in muscle disease, that is a peculiarity that it does not respect a nerve pattern at all. It picks up the muscle. Sometimes some of the muscle is affected, some other muscle not. One part of the muscle is affected, some part of the muscle is not affected.
Here was the rhomboids weak, sir?
It's also rhomboid, it's also weak. I did not check that detail in this particular page.
Does this winging show that the rhomboids is weak?
The rhomboid swinging actually happens, the inferior angle will go outward. In the case of trapezius weakness, since it's inserted into the spine of the scapula, the upper angle will wing and go outward. In rhomboids, the lower angle will wing and go outward.
What is happening here? Is it outward or?
It is
normal?
outward. Oh, this is outward. It's much more deviated. This is the midline.
No, lower angle of lower part of scapula.
Here, it is not moving outward like that. But when you do the conventional testing, to elicit the winging of the scapula due to rhomboids, you have to put that muscle into action. So you have to use the conventional testing of the rhomboids. Then the winging will appear. You understand what I said? Because in this position, the rhomboids is not put into action. You have to put into action the rhomboid, then only make out the weakness of that particular muscle.
Now, what was the serratus anterior here in this patient?
Serratus anterior is normal.
Normal.
Okay. Any other questions? I'll come to that FSD later, little later. There's some pictures I will show you. Before that, I'll show 2-3 cases also. So, a 40-year-old man present with the history of inability to lift heavy weights above his head 2 months back. followed by inability to turn the key with the right hand. This is I was Pushpari, it's a case of Riji. No pain or no any sensory complaint. Okay. Inability to lift heavy objects above his head 2 months back, followed by inability to turn the key with the right hand. The weakness is remaining almost static since then. There was no neck pain, no complaint, no other complaints. Let us see the examination of the patient. Okay.
Support എടുക്കല്ലേ സപ്പോർട്ട് എടുക്കല്ലേ ഇതിനെ പിടിച്ചോ ഓക്കെ ഇനി നേരെ പിടിച്ചോ മടക്കി പിടിച്ചോണേ മടക്കി പിടിച്ചേ നേരത്തെ പിടിച്ചോ അന്നേരം പിടിച്ചല്ല എങ്ങനത്തെ പിടിച്ചേ മൈസസ് വർക്ക് ഇസ് ഓൾസോ ഓക്കെ നൂർത്തെ 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 ഇത് നൂർത്തെ മതി ഇത് പൊക്കിക്കേ ഇതും പൊക്കി
നോർമൽ
എല്ലാം അകത്തി പിടിച്ചേ
Some wasting for the FD also. FD is weak in this patient. But
ഇത് പൊക്കിക്ക് മുകളിലോട്ട് പൊക്കിപ്പിടി ഗുഡ് തീന ഇത് പൊക്കിക്കേ There's no thenar wasting. Thenar is good. Hypothesis also good. Tallike.
It's good power. Affected is good power.
Okay, മുകളിലോട്ട് ഫോമൻ സൈൻ എങ്ങനെയുണ്ട് മൂർക്കി പിടി വിടരുത്
പോസിറ്റീവ് but see
the hypothenar is tallike see very good power what tallike
that's also good power
tallike ഇത് അതേസമയം വീക്ക് ആണ്
weakness of FDI
ഇത് ഇങ്ങോട്ട് തള്ളു അമർത്തി വെച്ച്
biceps with 1 plus
ഇത് എൻ്റെ കയ്യിലോട്ട് തള്ളു
press penetratus was weak bilaterally
എങ്ങനെ വെച്ചേ
press penetratus also
വെച്ചിട്ട് ഇവിടെ തന്നെ ചേർന്നിരിക്കും എൻ്റെ കയ്യിലോട്ട് തള്ളിക്കൊണ്ട് തള്ളിട്ട് ഇത് ഉള്ളിലോട്ട് തള്ളു
that also I couldn't do. That's a rhomboid testing. That is a rhomboid. So I'll summarizing the finding. He had weakness of both deltoid, supraspinatus, infraspinatus, weakness of upper trapezius bilaterally, no weakness of serratus or rhomboidus. Biceps mild weakness, triceps is normal, forearm muscles normal, and weakness of both interossei, mainly FDI, abductor pollicis and adductor pollicis, performance is positive, but the other thenar hypothenar muscles are normal. Okay. DTR or decreased biceps and supinate, triceps normal. So where is the site of lesion? What is the likely diagnosis?
It's again a muscle disease because only certain muscles are involved and some parts of an individual muscle are sprayed.
Yeah, right. So it's a selective involvement. Why not motor neuron disease? Can be a motor neuron disease?
This amount of selectivity is unusual in motor neuron disease. And is there any wasting?
That's wasting on the FDI.
Yeah, but no fasciculation.
No fasciculation. As I said, the most likely muscle, because it's the symmetricity. There are two things: selectivity and symmetricity. One key point, as Joy was telling, it's a selective involvement is classical muscle. But some patchy involvement can also be anti-involvement, and we are not sure whether it is a selectivity or patchy. Moreover, the symmetricity, when it's occurring bilaterally, is unlikely in the same muscles affected bilaterally, unlikely to be an anti-musculosis. That's the 2 points we should take in muscle is. Which muscle is? The question is which myopathy you consider.
FSHD again.
Let us see. Now let us see what is striking selective affection. So bilateral affection, we should make you think. Now, see this one. He again, trunk goes back on extension. You see this? Trunk goes back on extension. Now on the patient.
See the clavicular head. It's a good power. See the clavicular head. നല്ല bulk ഉണ്ട്. At the same time,
but
sternal head അടുപ്പിച്ച് വെച്ച് പിടിച്ചോ.
The sternal head is weak.
And symmetrically, this is also
the same muscle itself. One part is good power, other part is weak.
These two folds here.
The clavicular head once again.
And symmetric is weak. It's weak. Time. നല്ല bulk ഉണ്ട്.
Head, so how good it?
At the same time,
but sternal head
അടുപ്പിച്ച് വെച്ച് പിടിച്ചോ.
Again pointing to the fact that that's likely to be a muscle. So this thing is also, it has no beaver sign. Beaver sign was negative. His trunk also goes back on an abduction of the shoulders, selective affection of sternal head pectoralis, sparing the clavicular head. So this is the previous patient again showing the same finding. This is consistently observed in many FSHD patients. Now, what do you want to do in this patient?
Sir, this is Murli from Hyderabad, sir.
But yeah, please, no problem. Please tell.
Sir, deltoid is involved, no? Is it, I mean, involvement of deltoid is fairly against the FSHD?
Yeah, correct. That is only lastly be affected, correct. You're right. Just to remember the previous patient, you have got bulky deltoid. Here, deltoid is weak in this patient. And biceps is not much affected. Usually, biceps is more affected than deltoid in biceps and triceps affected in FSHD than the other ones. But here they are spare.
Sir, in this case, apart from the partial involvement or selective involvement of the trapezius, is there anything odd against a bilateral plexitis?
Yeah, that's a point. In fact, previously diagnosed have brachial plexopathy, something without pain, but usually pain is there. But only distal muscle also is selective. That's the point. It's not fit, it's too selective. For example, you remember that is FDA is affected, the AD is not, the area separated by the or separated by the same root. That makes it odd and symmetrically affected. And his adductor body is also symmetrically affected. Within one nerve itself or one root itself, some muscle is shortly spared, some muscle is severely affected. That kind of selectivity is slightly odd in case of plexopathy. But possibility can be considered.
Sir, can bilateral plexopathy occur simultaneously?
Can plexopathy?
Bilaterally, plexopathy can it occur simultaneously?
It can occur. Usually, it follows one by the other. Here we don't know because this patient comes with right-sided weakness. He never came to us with the weakness in the left side. That is observed by us. That is very typical of plexopathies. They come with pain and weakness. On examination, contralateral infrared magnetism is weak. That means he must have had some plexopathy earlier, which were unnoticed. Even with weakness, he never became Cambridge notice because he's using his right hand.
Does the duration and static course favors the muscles?
Only 2 months duration. He's telling 2 months. It's a previous patient, no? He came with foot drop. Okay. He had no complaint of upper limb. See how much affection was in the upper limb. So unless the person is using that muscle for some in his occupational life, the weakness goes unnoticed. Suppose you are a doctor, you are in the habit of only writing. you are not putting any heavy logo put onto the lorry. You may have proximal muscle weakness of the upper limb, which may not be noticed by anyone because you are not lifting up heavy weight. On the other hand, a manual laborer, he may have mild weakness of the interossei, it goes unnoticed. But his problem is only lifting up logo put onto the lorry. That is his complaint. The examination, you find weakness in the vestigial small muscles. So all depends upon in which work or occupation you are doing. That will be the complaint of the patient. Okay, so NCV. Yeah.
Sir, one doubt, sir.
Please.
This patient had not presented with pain at all. So
No
can
pain.
that occur like that?
Yes, yes. You can have plexopathy without any pain. Without any pain. There are even classically in the hereditary neurology can be two types. One is without pain at all. Otherwise, that is why it can be part of your HLPP. Neurology
Yes. Yes.
So NCV was done.
Sir, can I skip one question?
Yeah, please.
Sir, in ulnar palsy also you can get the sparing of the ADM with involvement of the other groups.
Yeah, deep
like,
branch. If it is that is
deep
not,
yeah.
but it's not possible here because you can have deep branch, proximal part, and distal part. Even if the distal part is affected, the muscle affected should have been adductor pollicis and FDA. Here, what is happening? The FDA is preserved, adductor pollicis. Sorry, FDA is affected. So that's a possibility. Only it has to be the distal part. Then only you can explain that thing.
Yeah.
Distal part, deep branch, bilateral. So EMG was done. EMG showed fibrillations and positive sharpers and fasciculations from the deltoid and interossei.
Sparing of triceps again going into motor neuron disease.
But as told before, I usually give for clinical findings rather than anything. But this is the finding typical of motor neuron disease. So such a kind of a selective bilateral involvement, I personally will consider this thing. And another thing, till you look at the sternum-mastoids, clavicular head is normal. The sternum head is markedly affected. And again shows such a selectivity within the muscle. That is really odd for a motor neuron. It's symmetrically affected. So neurologic hemiatrophy, patient had already received 5 injections of IVMB from close metal. In fact, this weakness worsened according to the patient with IVMB. So what else you want? FSHD. Because this pattern, selective sternum-mastoid weakness, and then selective involvement of that particular trapezius. One possibility was FSHD. So muscle biopsy was sent. Histological features show myopathic features with neurogenic changes and sparse inflammation. Histological features compatible with FSHD, but are not confirmed. This is from the advanced report.
Are the EMG changes consistent with FSHD? So right?
FSHD can produce neurogenic pattern. It's one of the myopathies, just like our rimmed vacuopathies, all produce fibrillations and potentials, fasciculations.
Sir, what was the CPK?
CPK was normal. In FSHD, usually CPK is not elevated.
Would FSHD be detected by these exome analysis and all genetic studies?
I do not know. It's except I do not know. I do not know, Joy. I got to look up into that. I did not look into that. Now,
second case, the deltoid is so much thing, sir. So how can the first case or deltoid is hypertrophy? The second case, that is the main weak muscle.
Correct.
Both are FSHD.
Correct. I'll come to that. I'll come to just one more case. I'll come to that.
Okay.
I'll answer all these questions. I have seen FSHD presenting with unilateral ophthalmoplegia. When I was I was thinking of a pain for arthritis syndrome, but he had FSHD. I did not know that kind of an FSHD. I'll come to that. This another case, this man presented the foot drop left side for 2 weeks back, only 2 weeks duration. No sensory complaint, NCS was normal, and this is the patient, a short case. Okay. On undressing, this is the patient. It's also got the classical appearance of the FSHD with the wasting of the sternomastoid and scapula. Usually asymmetrical, epithesis is asymmetrical. So FSHD can present with acute foot drop. This is not the first case. I had seen previously another case, they present with acute foot drop. So these let's see the atypical phenotypes of FSHD. You can have facial sparing FSHD. FSHD PUO syndrome, they can present with unilateral or bilateral external ophthalmology syndromes. They can be confined to the limb girdle distribution. You said deltoid was weak in this patient. They can present with proximal upper and lower limb weakness. They can present the distal myopathy, which is symmetrical, like a foot drop in our patient. Both the first patient and this patient present unilateral foot drop. And asymmetrical brachial weakness, the second case. So these are the presentations of FSHD. I think the muscle pattern. Now I'll just mention a few sentences. A marked involvement of the abdominal and paraspinal musculature can occur, which can cause exaggerated lumbar lordosis or camptoconia. Unlike other muscular dystrophies, contractures around the neck muscles are not common. Pectus excavatum occurs more frequently. Now let us see this one. Other initial presentations have been described, including limb girdle weakness, isolated limb involvement, severe facial involvement in infancy, and bent spine syndrome. So one of the 2-3 important signs, they can have flattened transverse smile or flattened pucker and inability to tense the platysma when asked the patient to growl. Another appearance is tapir nose appearance of the lips, because when you ask the patient to blow, the lower lip will not contract, upper limb will contract. It can be various steps. Sometimes maybe come to the upper part, it may be converted to the lower part. The phenotypic variations are very, very extreme in case of FSHD. Deltoid is often preserved, and the trapezius can appear bunched up because of the selective involvement of the lower part of the trapezius, giving rise to the so-called polyhill appearance of alternating muscle and bony landmarks. Muscle biceps and triceps are often wasted with the preservation of the distal forearm, giving rise to the so-called Popeye arm appearance. The shoulders wasting of the rhomboids can occur with lateral displacement of the scapula. Winging of the scapula can be seen active shoulder abduction or forward flexion, often with inability to move beyond 90 degrees. From the front, the tip of the scapula can often be seen above the clavicle. That is the scapular hump sign. And axillary fold, you can see the axillary fold. So look at this patient again. Also, the trunk goes backward. This is consistently observing in many patients. They get the trunk goes back. Standing is okay. Whenever elevate the arms, it goes backward. So that's the story of FSHD. Now you can ask questions. Now I have showed you 3 presentations. So what? Remember that FSHD can have a typical presentation. Can present foot drop, ophthalmoplegia, or something mimicking a unilateral brachial plexopathy.
So the facioscapular human dystrophy face is hardly ever affected. So why the name is still retained?
Some of the FSHD severe facial weakness will occur to the extent that they cannot close the eye. Severe. All depend. Let's say the phenotypic presentation or variability is gross in FSHD. That's why that is the point why I brought the 3 cases together.
FSHD can be diagnosed by genetic studies, sir. Both FSHD 1 and 2, they are diagnosed by genetic analysis.
Okay.
Codexes.
Okay.
Sir, a genetic test is available for FSHD for chromosome 4.
Okay.
So, do you do it?
No, I did not do. I was not knowing about that because the phenotypic present is so typical. So usually in FSHD we don't do any genetic test, but if you click the brain, it can make it.
Okay, thank you.
Only when the footnote comes, then the problem came. We had seen the patient undressed earlier before looking at the foot. Maybe what happens when they come with foot drop, we hardly look into the upper limb and all. We concentrate on the foot only.
Madhu?
Yeah, please, Subhash sir.
No, I think other point to be highlighted is that the presentation can sometimes be acute to subacute, even though the disease has been progressive for quite some time.
Exactly.
Right? I think that's also.
One more thing, even I have observed, even literature given that they can respond to steroid also. I'm saying. The other patient, he had foot drop improved with the steroid. And this is described in literature also. The reason why they are offering in that literature says that because unlike the other classical muscular dystrophies, FSHD is associated with inflammatory changes in the muscle. You find inflammatory cells in the muscle biopsy. Probably the inflammation also can contribute to some extent. Anything you do not know.
So Madhu, one more related question I had that, we often try to differentiate this winging of scapula. Is it because of serratus anterior? Is it because of rhomboids? Is it because of trapezius? Is it really important? I mean, other than traumatic nerve injuries, in most of these muscle diseases, is there selectivity does it really help us finally in the diagnosis? That is it because of serratus? As long as we see it's winging, that's okay. But how is it important for us to know that which muscle is causing it so far as the diagnosis is concerned?
And we need to know that because they are separated by different nerves. Suppose a person coming with serratus weakness, we know it's long thoracic nerve is affected. If trapezius is affected, we have access to the then it helps in where you want to place. If it's trapezius there, you have to think of it, we should access accessory. Those who are speaking out, please mute.
Can you please mute all the other mics, Manasi? Some noise in the.
Please, yeah. So depending on since it's important because nerve supplying is different and the area of origin is also different. For the spinal accessory, it is coming from this in the central part of spinal cord going. The lesion can be anywhere at that level. Whereas in the serratus and his weakness, it is in the brachial plexus region, the root of the brachial plexus region. So it helps in localization which part is affected. Whereas if you find winging due to trapezius, we are not thinking in terms of a brachial plexopathy at all.
Okay, Madhu.
And rhomboidus winging is important because that is the muscle which is typically the sole muscle affected by C5 root. All other muscles got combination, but the main dominant supply of C5 root is rhomboidus. The other deltoid, biceps are now got brachioradialis, all contribution by C6.
Okay, sir. Thank you.
One of the segment muscle C5 is rhomboid. So that.
Yeah. Thanks.
Thank you.
Next case.
Okay. Okay. This is also another interesting case.
Sir, one down.
Please.
Sir, is that the reason that the nerve and we got the absent reflexes in the first case? That knee jerk and they say the nerve involvement is there in FSHD. So is that the reason why absent reflexes are occurring?
Nerve involvement is there. I said only fibrillations and fasciculation are described. So that may be due to due to the inflammatory changes. See, seen in inflammatory myopathies, you find fibrillations and positive vascular disease.
Yes.
That is due to the myonecrosis and producing affection of the intramuscular nerve fibers.
Yes, sir. Yes.
Nerve
Okay.
fibers within the muscle.
Yes.
Such case, usually you don't wait see fasciculations, but only fibrillations and positive waves.
Okay.
So this story of a 75-year-old lady, her complaint started, this is a long story, but interesting. 7 years back, as blurring of vision while reading, which improved on closing one eye, and diplopia of looking down. This has been for 2 years prior to that. She came to the hospital 7 years back with the history 2 years. The total duration is about 9 years. So this is the report here. That is in this is 2015, 1 till 2015. There they are written intermittent and blurring of vision on looking down for 2 to 3 years. That's the story. Head tilt to the right side. Again written there. This is from the ophthalmology hospital. Written again, intermittent diplopia, head tilt to the right side. Left hypertrophy. More likely this is suggestive of a superior oblique palsy on the left side. So they diagnosed left fourth nerve plus inferior rectus weakness with fluctuation. Thought of myasthenia gravis with arroophthalmoplegia. RNS, anti-TP, etc. was done at that time. So the patient was put on neostigmine, even though RNS was not confirmed. This is NCB done at that time, 2015. You can see the date. NCB was normal. The RNS was also not positive. But in one time it was given as a decrement, which I am not believing because so highly variable values are given, probably a technical fault in the right patient. So in 2015, the patient was put on pyridostigmine. Then 2 months later, they say 60% symptomatic improvement. So they continued. Followed 1 year later, that is, this is 15, this is 2016. Again, they said there is improvement. They continued on that. 17, 18, again, this is better. Not much problem. Then 11, 2018, and November 18, she underwent cataract surgery bilaterally. Okay. Then January 2019, patient developed ptosis of the left eye. The left upper eyelid, the upper eye was covered, the eyelid covered up to half of the palpebral patient. That is according to the history. So the doctor increased the dose of pyridostigmine, and the ptosis improved over a period of 1 year's time. Ptosis became cleared, but for the last 1 year, patient noticed that ptosis has totally improved, but the patient noticed the left eye has gone up. For the last 6 to 8 months, patient noticed numbness over the left side of the nose and medial aspect of the forehead. She is pointing to the angle between the nose and the forehead. I think this is the history she is pointing to.
അപ്പോൾ മരപ്പുണ്ടെന്ന് പറഞ്ഞില്ല 1 വർഷമായിട്ട് അതെവിടെയാ?
This is the area she is pointing to where the numbness is.
അതിപ്പോൾ 1 വർഷത്തോളം കണ്ടിട്ട്. അപ്പോൾ അവിടെയാണ് അത്രയും ഭാഗത്താണ് മരപ്പ് ശ്രദ്ധിച്ചത്. അതിപ്പോൾ എത്ര നാളായി അത്?
Okay. This is.
അപ്പോൾ മരപ്പുണ്ടെന്ന് പറഞ്ഞില്ല 1 വർഷമായി.
Okay. Now let us see your examination. So if you want the history once again, this is the key history. She developed ptosis, which improved with treatment. Then they noticed that the eye has gone up. Then noticed for last 6 months numbness of the root of the nose of the left side.
അപ്പോൾ മരപ്പുണ്ട്.
Let us see the examination.
എൻ്റെ വല്ല കാണാം അമ്മയ്ക്ക്. മുകളിലോട്ട് നോക്ക്.
Looking up, the left going up. Looking down, left eye is not going down. Flash on the left side.
ഇടത്തോട്ട് നോക്കമ്മ. എൻ്റെ വെല്ല കണ്ടല്ലോ അമ്മ. ആ നോക്കിക്കോ. വെല്ല എൻ്റെ വെല്ലത്തിൻ്റെ തുമ്പത്ത് തന്നെ നോക്കണം കേട്ടോ അമ്മ. ആ മതി, കുഴപ്പമില്ല. കാണുമ്പോൾ നോക്കിയാൽ വെല്ല ഇപ്പോൾ കാണുന്നതോടെ നോക്കിയാൽ മതി.
The left side. The right side, left eye vertex. It does not come down, adduction as well as in abduction.
മൂക്കിൻ്റെ അടുത്തോട്ട് നോക്കിയേ.
It's not external.
ശരി, ഇനി താഴോട്ട് നോക്കുമ്പോൾ
Looking down, the
എൻ്റെ
side
വല്ല്
is
കണ്ടില്ല, താഴോട്ട് നോക്കണേ. വല്ല് തന്നെ നോക്കുമ്പോൾ അത് തന്നെ കറക്റ്റ്. ഈസ് നോട്ട് കമ്മിങ് ഡൗൺ. ഒരു മിനിറ്റ്.
pupil is symmetrical, slightly dilated on the left side, and irregular pupil. It's not reacting well. Underwent cataract surgery.
ഇട്ടമ്മ ഇതും വ്യത്യാസമുണ്ടോ?
So decrease
അവിടെ കുറവുണ്ട്. ഇതും
reading
തമ്മിൽ
part of the nose.
ഇനി ഈ കുത്തുന്നതും ഇതും തമ്മിലോ? ചെറിയ വ്യത്യാസം വിട്ട്, നല്ല വ്യത്യാസം ഇല്ല.
On the cheek, it is normal. Only is decreased on the left side.
ഒന്നുമില്ലമ്മ. ഇറ്റ് ഈസ് ഡിക്രീസ്ഡ് അല്ലേ? മുകളിലോട്ട് നോക്കുമ്പോൾ അങ്ങനെ നോക്കിക്കോ. മുകളിലോട്ട് നോക്കുമ്പോൾ കണ്ണ് മുറുക്കി അടയ്ക്ക്. മാക്സിമം മതി. കണ്ണ് തുറന്നേമ്മ. നെറ്റ് ചുളിച്ചേ മുകളിലോട്ട്. കവള് വീർപ്പിച്ച. അതുവരെ നേരത്തെ പറയാണ്. വിട്ടോ അമ്മ, വിട്ടോ.
Okay. This is the examination.
എൻ്റെ വല്ല കാണാം.
Then I did the look for the pit.
കണ്ണ് മാറ്റാതെ നോക്കിക്കൊണ്ടേയിരിക്കണം കേട്ടോ. അല്ല, രണ്ടായിട്ട് കാണുന്നുണ്ട് അല്ലേ? കണ്ടോട്ടെ വല്ല കണ്ണ് ക്ഷീണിച്ചോട്ടെ.
Okay. So on examination, lid lag on the left eye, pori on the right side as well. Left eye is deviated up and out. There is a restriction of elevation, adduction, and total restriction of downward movement in both adduction and abduction. No intorsion or extorsion of the left eye on looking down. There is anisocoria, left more dilated compared to the right, and left pupil is irregular and sluggishly reacting to light. Right pupil is sluggishly reacting to light, and left pupil is not showing a reaction. So this is the story. So what do you think?
A mass lesion causing either vascular or non-vascular, causing compression of the trigeminal and oculomotor on the left side, either cavernous sinus or trigeminal cave.
Trigeminal and?
Cavernous sinus or trigeminal cave or adjacent perimesencephalic regions.
No, first of all, which are the nerves or muscles affected, and you have to nerve involved. Then you have to come back to localization. That's the thing.
Partial right.
Ophthalmic division, trigeminal nerve, and ophthalmic division and division is involved, sir, and also oculomotor nerve on the right side, left side. Sorry.
What about fourth nerve?
Eye muscles.
Fourth nerve also involved, sir.
Pardon? Now, Bindu, what you telling?
The eye muscles affected were inferior rectus, then
medial rectus,
medial rectus, and superior rectus, and both obliques, because the eyes were not intorting or extorting on looking down.
Very good. So that means superior oblique is also affected.
Yes.
The first muscle affected might have been superior oblique.
Superior oblique, yes.
Because the history telling that at that time they were telling left eye was up, and the patient was is comfortable on turning the head to the right
side
and worse than on turning to the left side. That shows he's got a Wilczewski tristus suggestive of a superior oblique palsy.
Left superior.
And the other muscles affected was that of the third nerve, the region of the supply of third nerve. And the sensory loss was in the nasociliary nerve distribution.
Yes, sir.
The fifth nerve has got, the sensory part has got 3 divisions. The ophthalmic nerve division of the fifth nerve has got 3 divisions: frontal, lacrimal, and the nasociliary. Here it is in the distribution of nasociliary nerve. So where do you think the exact localization you like to keep in mind? The pupillary involvement we can't give much importance because patients are not cataract side.
Could be in the orbit, sir.
Maybe in the orbit or in the superior orbital fissure region.
Yes, sir. Cavernous
But
sinus
when
because
the
it is
optic
too.
nerve is involved, sir. So the superior orbital fissure.
Yeah, optic nerve is not involved as such.
So it could be in orbit, sir.
Could
Sir,
be, yeah, the point again, it could be in the orbit or in the
But the
antecover.
lateral rectus is normal.
That may all need not be affected. That lectus is normal here. So,
sir, sir, in this case, since she is not able to look down or addicts, it's possible that there is a contracture of the the muscles, either the superior rectus or the superior oblique on the left side. And additionally, as you mentioned, part of the fifth nerve, the nasociliary is affected. So probably some inflammatory lesion behind the orbit is operating in this case.
yeah, actually said correctly, there will be a contracture of the superior rectus is possible, or the weakness of the inferior rectus. Both are possible, no? The person eyes gone up means it can be due to the weakness of the inferior rectus or contraction of the superior rectus. Both are possible.
Yes, sir.
But nerve is more likely because the involved muscles are in the distribution of the nerve. That's the point you have to take into consideration. The superior rectus, medial rectus, inferior rectus are the distribution of the nerve pattern. At the same time, lateral rectus is preserved. So that point plus the sensory involvement point to that it is like the lesional activity in the nerve.
Is superior rectus involved?
Superior rectus here because elevation is restricted compared to the right. Even the right has gone up. It is not looking up. I will show the video 1 second.
Sir, anterior cavernous sinus can be involved because the mandibular division, everything is paired. Only the nasociliary of the ophthalmic.
Yeah, that's what it is. Anterior cavernous sinus or superior orbital.
Or superior orbital. And it could be something like a vascular or something which is pressing rather than an inflammation because it's a quite long history of 7 years. Inflammation down the line in this old age, she may not be this much present.
7 years, 9 years.
9 years.
7 years she first attended. At that time, the myasthenia and all. Now, my question to you, I'll come to that later on, that particular question in this case. So these are the possibilities you have to keep in mind. Okay?
Yes.
And this thyroid ophthalmology, sir, because she has got a lead lag and all the other.
That's a, he has got lead lag bilaterally. It can be thyroid disease.
Restrictive eye disease.
Would be, sir.
Yes or no?
Yes.
No, sir. There is no exophthalmos in this case. There are no other. Other findings of thyroid disease are not there. So I don't personally consider.
Exophthalmos may not always be there in a thyroid.
Exophthalmos may not be there, but it usually bilateral, but it may unilaterally also can occur to begin with. But there are obvious points again is because his pupil is affected. If you can take it due to that thing, and sensory loss cannot occur.
Yes, sir.
It's got a that means that cannot be explained.
With the sensory loss in the nasociliary, the muscle is out, sir.
That's sensory part. That means its nerve has to be implicated.
Yes.
So, if a chronic inflammatory process like a sarcoid or IgG4 disease can present, indolent way.
Perfectly right. What you said is perfectly right. That's a possibility you have to keep in mind among the infiltrating lesions.
Can they stay for quite long time?
Yes. IgG4 disease as well as idiopathic, for example, idiopathic vacuum meningitis, so they remain for many years. Now let us see one more point. See, initially she had ptosis. That is very clear, and that disappeared. Why is that? And she has got literally, so on asking the bed, look down. You see, I'll show you the picture again. Looking down, the left eye is not coming down.
That means infiltration, sir. Fibrosis.
Fibrosis. What else is possible?
I'll
I'll come to that possibility later. So what do you want now? Let us see which are the muscle surface already said it correctly, so I will not tell again. You want MRI, no? Okay. This MRI was done twice, both in the same month itself. This patient came with this MRI. I'll run by one slowly so that you can find out. If you want to stop in between, ask me to stop. I'm concentrating only in that area. I don't go to all the pictures unnecessarily. Is going up. Paracellular region. Okay. Sagittal cut. Coronal cut. T2. T1 weighted sequence. Sphenoid area. The paracellular region. The blood investigation, I think skip this one. Blood investigation TSH was normal. Then ESR was 6. Other precondition normal. Blood sugar was mildly elevated. Thyroid was also normal. Rheumatoid factor negative. So what else you need? So to repeat
Contrasted?
repeat the MRI once again. You asked for a thin cut as well as a contrast study, which the patient not come with a contrast. So I will show you the thin cut as well as both the contrast fillings. This is the flyer sequence. This is a cis sequence. This is a swan sequence. This is a contrast. I'll show the plain and contrast later on, comparing both the things. This is the plain and contrast. Okay. I'll keep it for half a minute so that you can see. Then this next upper level. Then coming to our area of interest, paracellular region. Again coming to our area superior orbital fissure region. Supracellular region. This is a zoomed up view of the paracellular region where we are interested in, and superior orbital fissure region very interested.
So there is that lesion in the left and in the orbital apex and adjacent to the anterior, in the anterior cavernous sinus also, which is enhancing on contrast. And here you can see it in the...
This affection is on the left side.
Left side, sir. On the left side, between, that one, that one, yes.
These two, this is normal. It's not abnormal. There's no area of abnormal enhancement here.
Right side.
This is right. This is left. Here you can see the enhancement. This is little bulky here.
Yes, sir. That one.
That is significant. This cut is
yes, sir. So intracavernous, there is a lesion, and also it extending to the orbit of the orbital apex on the left side. It's enhancing on contrast.
Correct.
Are the muscles getting enhanced?
Muscles, normally muscle will enhance in even with contrast.
Is it hemangioma or something like that, sir?
Let us come to that. I'll show the whole picture now. So let us say this is the, I'm showing you the full picture again. This is the orbital cut. There's a C sequence. Now let us see the abnormal findings.
There is a atrophy in that muscle.
Yeah, so you can
written.
So the medial
That
rectus,
on the medial rectus is appearing thinner than the.
and the maximum of this is superior.
Superior oblique.
On the left side, superior pubic on the left side, male rectus is atrophied, inferior rectus on the right and left, superior rectus on the right and left, they're all atrophied. The lateral rectus is okay. I'll show the other picture also, the cut also. Superior oblique, that's superior rectus. Again, you can show the video of the patient. Got the middle rectus that's in superior oblique line. It's hardly ever seen. The inferior rectus side, the left side.
Okay, that's atrophy.
Lateral rectus is okay. The lateral rectus bilateral. Good. The rectus also good.
But less than that of the inferior. That's a middle rectus atrophy.
That means muscles have become fibrotic. Huh?
Okay.
Long duration, right? This is the coronal T1 again, right? Forget about it. Let us see. Now let's see what is happening. There is some thickening in the dura on the left side.
Okay, right.
Outer margin of the right here, then it's right. It's a thickening of the dura on the left, the wall of the lateral side. Let's see. That is without contrast.
What is that structure?
Let us see the enhancement here. See, this is the right and left. You can see the wall of the cavernous sinus is enhancing. Again, you can find an enhancement compared. This is the plane and the contrast entering side by side. And you can find out this area and this area. This corresponding T1, the T2 area, this wall is enhancing. And you can find out the third nerve is also bulky on the left side. This is the third nerve. This is the 3D flare sequence in which you find out this abnormality. This again, the arrow is pointing to the third nerve. This all I did not pick up, on my radiologist picked up these abnormalities. Other things I picked up, this only he could show me these things. So this is the third nerve again. But he expected enhancement. There was no enhancement in the third nerve. Only the cavernous sinus wall was enhancing. So what is likely diagnosis now?
There one doubt.
Yeah.
The atrophy of the extraocular muscles, what clue does it give? Is it give because of the denervation, atrophy, or it is the inflammation of the muscle which produces this?
So obviously here is a denervation causing atrophy. It's a long-standing process. Axonal loss, muscle has gone into atrophy just like any muscle. Yeah. Right.
Sir, could it be that there is a burned out process which has caused an adhesion between the bulbar conjunctiva and the inside of the lid, which has caused the improvement of the ptosis?
Yeah, exactly. That's my next question. Okay. So there are two things what you said correctly, Ruba, that there may be a contracture or adhesion, which is more likely rather than adhesion, because it's not a local inflammatory lesion there. It's most likely contracture of the muscle can occur. When the LPS goes into contracture, the eyelid retracts. Okay. So that is what might happen here. The other explanation is that in chronic pathologies like this, the nerve goes into aberrant reinnervation. Aberrant reinnervation means that the muscle fiber, the nerve fibers destined to go to the inferior rectus get misdirected and go to the other divisions of the third nerve. For example, here the upper division going to the LPS. So when the patient is asked to look down, the eyelid will go up. So in this case, there is a better possibility. There may be a contracture where we can explain the persistent elevated position. But when the patient is looking down, the eyelid goes up further. That shows maybe an aberrant reinnervation. Did you get my point?
Yes, sir.
Yeah. Going on command, look down means you are putting the inferior rectus into action. Inferior rectus is not working at all. So the impulse is what is because the reinnervation has gone under the LPS, LPS contracts whatever LPS is present there, contracting it further. So these are the two possibilities which can explain this thing. Upon the innovation, the LPS with fibers distant to the left incorrectors and contracts the left LPS, as I already said. So this most likely a localized form of vacuum meningitis, most likely idiopathic, less likely to be to maybe other possibilities are quite. In fact, patient is now admitted there. We are doing a CT chest for hilar gland and CSF for any changes, ADA level and all. The result has not come. But whatever it is, a very chronic form, it's idiopathic vacuum meningitis. No, the thing how he had presented, that's the thing important. Long duration, present initially mimicking myasthenia, responding to diagnostic. Any questions?
So this is one example of this vacuum meningitis presenting in like a SLE, like very many forms, like long standing and asymptomatic.
Usual vacuum meningitis, what we see is a diffuse vacuum meningitis. But there are some localized forms, can confine only to the paracella for a long period of time. That is quite unusual. And I only seen one such case before presenting something like a CP angle lesion, confine only the CP. There is no mass there, anything there. Ultimately found out to be a focal form of vacuum meningitis. She improved with steroid.
Sir, in this case, does force reduction do any help in this case?
If it is gone into contracture, then you can help to differentiate. We can do that in this particular patient. Should we do that? Yes. Can differentiate between aberrant reinnervation and the contracture. What is it is correct? Any questions?
Actually, if the contrast is not done, we could not have found out, sir.
Yeah, we could not have found out. Because that's the importance of neurological examination. I always teach one thing. All investigation comes second only to the clinical examination. Because that tells you where to look for. Because that is why.
Madhu, sorry, I missed. What about CSF?
CSF, I mean, if I had done only, I didn't get the result. He was admitted in the hospital in Cochin, in Travancore Hospital.
So now, what do we see from time to time vacuum meningitis in different areas, and these days we talk of IG4, antibody. What do you think is the etiology of these? You think there is any etiology, or this was idiopathic? What do you think?
Most likely idiopathic. Sarcod, any other condition should have been progressed little more. Remaining like that for a long period of time, I think it's idiopathic.
You wouldn't consider doing biopsy in such patients?
Yeah, in fact, I wanted to, but very, very difficult to get a biopsy from that area. I had discussed with the neurosurgeon for that thing, very difficult. Because
vacuum meningitis thing, previously we used to think, all of them we used to, I mean, I'm talking of 20 years ago, all of these we thought assumed to be TB and even put them on TB treatment. Then it was thought it is some idiopathic hypertrophic meningitis. And now the latest thing is these are all IG4 associated things. So I just wanted to know what are your thoughts.
The problem with diagnose IgG4 is also extremely difficult. We can't do serum. That is not specific at all. Even because most of the time serum will be negative. You have to get a biopsy from that area and send for IgG4. Again, you need a biopsy.
Because now the question is how long you will treat it, and you will. I mean, you have given 2 weeks steroids, but what after that?
So here,
you just leave it.
This particular patients, I have put him on steroid followed by mycophenolate mofetil. That is
how long? How long you will give?
Continuously, years.
Right.
There was in progress one after another. Yeah. Now his cornea is getting affected. It may get involved again. Then other nerves get involved.
Sir, is she having any psoriatic lesions? By her tip of the nose is hypopigmented.
Right. That I did not give him. I did not look into that. But the clinical picture, yeah.
Sir, now that you have started on treatment, what kind of an improvement do you expect to see, sir? If you are expecting anything to see, or
No, I don't expect an improvement much. The only thing is that whatever left behind, some improvement may occur. But more importantly is that prevent further progression. You're going to progress again. Because look at, see what is happening for the last 8 months, she has developed the cornea is getting in, sensory losses appeared. So that means going to get on, another and also going to get involved one by one. Initially start with superior oblique, then other nerves got involved, then fifth nerve.
Sir, in this case, was it possible that she received steroids initially that would explain the improvement in ptosis?
In fact, from the records, it is not there. They are only periodistic. I have shown that papers with them, no? Photo of the paper. There is no history of having given steroids at any time. Okay, shall we stop now? It's because 10:30 we got
Yes, sir. Yes, sir. Yes, Madhu. Thank you so much.
Thank you,
sir.
Thank you, sir.
Thank you, sir.
Thank you.